presentations, that would be great.
This is Gary Cohen. I'm the president and co-founder of Healthcare Without Harm and Practice Green Health. Greetings.
Hi, and I'm Jessica Wolf. I'm the U.S. Director of Climate and Health for Healthcare Without Harm and Practice Green Health. And just joining Gary for the presentation and any questions that come up. Nice to meet you all, and thank you for the opportunity.
Hi, I'm Thomas Doherty. I'm a psychologist in Portland, Oregon, and past president of APA Division 34. Thanks for having me.
And Robert Bonner. Not here, or not making through, not getting through. Walt Vernon.
Yes, this is Walter Vernon, and I'm the CEO of an engineering firm in San Francisco.
Great. So I want to thank you all for being here. And I guess the order that we have you on the agenda is starting with Gary and Jessica, then Robert Bonner, if he is here, then Thomas Doherty, and then Walter Vernon. And we have 2 hours for this, so we should have time for a robust discussion.
Great. Annalee, is that the first slide in the presentation, or there was? Yeah, there you go. So I'll start. This is Gary. So, Healthcare Without Harm's approach toward the health sector is that in this time of the climate crisis and COVID, the mission of healthcare actually needs to expand beyond individual patients and to see the community as the patient in many ways, and the broader environment as the container at which all these activities live. So our view is it has to be, healthcare has to be thinking at 3 scales: the individual, the community, and the planetary health scales. It's no longer possible to have healthy people on a sick planet. Next slide. We have, over the last 25 years, built a whole series of partnerships, initiatives across 65 countries around developing environmentally responsible healthcare. In the United States, about 1 out of 4 hospitals is part of our network. Just gives you a sense of the scope. Next slide. I'm not going to go into details about this slide. It's an important slide from the Center for Disease Control, but it's a combination of rising temperatures, more extreme weather, rising sea level, and more CO2 in the atmosphere contributes to this enormous level of and variety of health impacts. Everything from the spread of infectious diseases to asthma, to respiratory impacts, to heat-related illnesses. It goes on and on. So you can look at this at your leisure, and there's a lot to back this up. But that's the context. Next slide. In addition to the health impacts, extreme weather events are also causing huge financial cost and disruption. Last year, there were 14 separate billion-dollar weather and climate disasters across many different parts of the country. And in many of these situations, the health sector itself is threatened to continue to operate, as well as, of course, all the additional people who are injured and are needing help to go to healthcare institutions. Next slide. In addition to being burdened by climate impacts, the health sector itself is a large contributor to greenhouse gas emissions. We've done a national report, international report, that looked at the overall impact of healthcare. We found that the healthcare sector was responsible for 4.4% of global emissions. To put it in context, that means the emissions, the annual emissions of over 500 coal-fired power plants. So healthcare is also contributing to health impacts related to climate crisis around the world. Inside of that, the United States represents more than 1/4 of all the global emissions from the healthcare sector. If you add China, the European Union, and the United States together, that's more than 50%. So it gives us a sense of important places to target as we move to address this. Next slide. If we align with the goals of the Paris Treaty and we begin to reduce dramatically the greenhouse gas emissions of the health sector, it'll be very, very critical. If we don't, the potential predictions are over the next 25 years, its contribution will triple, which is completely, unacceptable. Next slide. So at the heart of all of this is fossil fuels. It's both the leading driver of the climate crisis, but also on its own through its emissions is harming public health through extensive air pollution around the world and in this country. The WHO estimates that fossil fuel air pollution kills more than 4 million people annually. So that's an enormous amount of deaths, and there is no global fund for air pollution as there is in AIDS, malaria, and TB combined, but this is actually more than all of those infectious diseases combined. Next slide. So the important point here is that we think healthcare has a unique opportunity of any sector of the economy to play three fundamental roles. One is addressing its own climate footprint, detoxing from fossil fuels and toxic chemicals, and industrial agriculture, addressing its footprint. The second is anchoring the community resilience, both in its own infrastructure, so it can be the last building standing in extreme weather events, but also being able to anchor the resilience of communities. And we're seeing that play out in the COVID crisis in a major way. Third is leading broader societal transformation. That means policy and practices and broader education of the public about the links between climate and health, and advocating for policies that move us away from our addiction to fossil fuels toward a renewable energy future. So I just want you to hold those three roles, and we're going to go into short detail about each one of them and then some policy recommendations. Next slide. So just one more thing is that healthcare has been moving over the last 10, 15 years toward addressing the upstream factors that are making people sick in the first place, the quote unquote social determinants of health, bad food, poor housing, racism, lack of economic opportunity, social isolation. And in that, all of these conditions that are contributing to chronic disease in America are exacerbated by the climate crisis. And by the way, by COVID. We're seeing that it's not an equal opportunity impact. It actually is a force multiplier for all those same environmental and social impacts. You might say that climate is the elephant in the waiting room. The next slide. So we created Healthcare Without Harm has created a leadership group inside of the broader healthcare sector of 19 healthcare systems to pilot and to learn from each other as they develop these three roles. So you see who they are, lots of very brand name healthcare systems. Next slide. They represent 500 hospitals, about 1 million employees, over 200 billion in annual operating revenue in 36 states. It's sort of the shock troop to get the rest of the sector to adopt these climate strategies, climate smart strategies as a whole. And actually the National Academy could be very helpful in helping to move that through policy as well. Next slide. So on the mitigation side, on the kind of detox side, there's so many proven strategies that these hospitals have already learned about, reducing their reliance on fossil fuels, making commitments to renewable energy for electricity, reducing the amount of stuff in the operating room, switching anesthetic gases from desflurane to alternatives, moving toward telemedicine, moving toward more plant-based diets in the food they serve patients and employees, sourcing from local suppliers, reducing the amount of single-use plastics. There's a whole broad set of strategies that have been proven. Many of them, and most of them, have also saved the hospitals lots of money and have also improved patient sensibility. Go back one slide. And the framework is all around these 8 different dimensions. I won't go through them all, but each of them has a whole set of interventions that are proven, that are being worked on by hundreds of hospitals around the country and around the world. Next slide. Yeah, so this is an example to show you the level of momentum of a number of these systems that are making commitments in alignment or even better than the Paris Climate Treaty in terms of renewable energy, in terms of carbon neutrality, in terms of organizations like Kaiser, carbon net positive by 2025. So a whole set of mostly nonprofit systems that are all moving in the same direction and learning from each other as they figure out how to finance these things, how to make the business case for these things. So it just gives you a sense of already there's lots of momentum in this country. Next slide. So that's a whole boatload of activity around mitigation. On the resilience side, you know, as we saw in Hurricane Katrina and Sandy and so many other events, Harvey, healthcare is on the front lines of climate impacts. It's also obviously on the front lines of pandemics. And in many cases, in these disasters, we've seen that hospitals actually have to be evacuated because they haven't been designed with a climate lens. They've got all the electrical equipment in the basement. They don't have on-site power to operate if the grid fails. Next slide. And so we did a study with PricewaterhouseCoopers that looked at a few of these hospitals and their broad impacts around what happens when you're not prepared, when you actually have to evacuate your hospital. And NYU Langone, through a combination of different interventions that happened, problems that happened, they lost $1.5 billion, which was the equivalent of 8 times the 2012 operating margin. So hospitals can't afford to lose $1.5 billion increasingly through these extreme weather events, because many of these things are preventable. And there's some policy solutions we'll mention. Next slide. Beyond the resilience of the hospitals themselves, there's a bunch of opportunities that we've created that healthcare can, actually there's checklists we developed with the Department of Health and Human Services that we're moving toward being implemented as policies before this new administration came in. It would get everybody, every hospital in America starting to use a checklist to figure out whether they're climate resilient and how to make interventions for that. That's a really big opportunity. Next slide. Beyond their own infrastructure, though, hospitals can also invest in the community. Cleveland Clinic is investing in an energy efficiency company that's providing for energy efficiency and renewable energy strategies for the community. They're investing in a greenhouse that's growing food, not only for themselves, but for the community. They invested in a cooperative laundry. They've invested in a climate action fund to support advocacy and education in the community using their community benefit dollars. So there's so many ways that healthcare, being such a big part of the local economy and politically savvy, can actually use their influence out in the community to build more community resilience. Next slide. Another example is in the Bay Area, where Healthcare Without Harm aggregated the purchasing power of the major hospital systems in the Bay Area, the UC system, Kaiser, Dignity Healthcare, and others, and then brought in the universities to say, look, if we can aggregate across all of our institutions around buying local and sustainable food, we can actually create a pipeline for growers in California and a place to provide jobs for people in the community, and then a distribution vehicle to bring out to hospitals and schools for healthy food. Next slide. So this facility, we were able to work with others to raise $20 million for a sustainable food production commissary. And in the context of COVID and massive unemployment and massive food insecurity, having a hub which is actually producing food, producing jobs, it gives us an opportunity to connect to a whole infrastructure in the Bay Area to address food insecurity in a way that's climate friendly. Next slide. The last role is as advocates. And again, nurses, doctors, pharmacists have the highest rating of any profession in America. David referenced it before. So leveraging health professionals as advocates inside their institutions as well as in the society is a huge opportunity that we're just at the very early stages of maximizing, because we want to put the face of climate and solutions to have healthcare be that face. Next slide. The reason to do it is because there's a great deal of denial. And at a personal level, we get that. You know, some people just want to go out and play golf and they don't want to pay attention to what's happening. But this level of denial is manufactured denial. It's the denial of 20 years of the fossil fuel industry, creating a sense of doubt, creating the sense that we're not sure about this, we don't know the impacts, and it's delayed action on this issue for several decades. And so bringing health as a thing that is absolutely crucial to people's main concern, as we see in COVID, bringing that to the forefront of our reason to act, and having health professionals as that trusted messenger is a crucial strategy for moving policy forward. Next slide, just a couple more. We've created a physician network around these issues. There's lots of other physician networks that we're partnering with. We created a climate challenge with another organization to educate and activate 50,000 health professional nurses in particular as advocates. I think there's a lot of room to build on that through nursing and physician education. Next slide. We created a climate challenge that brings these three components, mitigation, resilience, and leadership together, and sort of launched that around the climate treaty, and then saw who we could get involved. The next slide tells you that we got 200 participants representing 18,000 hospitals in 31 countries. Collectively, just in the reporting, they've been saving $400 million. And from the point of view of health, they've saved over $3 billion in health costs related to air pollution. So you see there's enormous co-benefits in this entire strategy for people's health and for the health of the climate. Next slide, last couple. So we have a couple of policy recommendations. They're more detailed, but a number of them have to do with incentivizing healthcare institutions to invest in energy efficiency through existing buildings and new buildings, to include hospital investments in clean renewable energy as an IRS reportable community benefit, some investments in research and development for alternatives to natural gas. I know Walt's going to talk about that. Next slide. This is a little more detailed. Certainly for safety net hospitals, they need direct grants or zero interest loans to be able to make some of these investments to be resilient in the face of the climate impact. There's a number of others. I'll leave that to the discussion. Next slide. On the resilience side, it would make a huge difference. Hospitals already have to report on for Medicare reimbursement that they're doing emergency planning. If they could add climate resilience, vulnerability planning into the existing recommendations, every hospital in America would begin to understand their own vulnerability as well as the vulnerability of the communities they serve. That's a really actionable strategy now at a policy level. Last slide. And there's more detail to that, but I'll stop there. Thanks very much. David, you're on mute.
Question at the end. Let's just say, are there any points of clarification for this, for Gary? Okay. Jessica, are you planning to speak, or are you just there as a resource?
I am just here as a resource and to answer questions during that Q&A.
Okay.
Thank you.
All right.
Sharon has a question.
Okay.
Just a quick question on how the projections are made about the billions saved on healthcare through the initiative that you described, Gary?
Yeah.
Could you say a word about that and the evidence where that comes from?
Yeah, so there was a leading researcher at Harvard University School of Public Health and Medical School, Paul Edging, that developed some algorithms around it. Once, when you reduce healthcare's emissions, especially around fossil fuels, there's a way that it can translate into health impacts reduced. The EPA built on that when they did the Clean Power Plan, and when President Obama at the time announced the Clean Power Plan, he was able to say, we are going to, we're going to be, by eliminating this amount of emissions, we'll be eliminating this many asthma cases, this many mortalities, this much healthcare costs. So there's been a kind of health economics that have built up over the last 10 years, I'd say, that are getting stronger and stronger about making these kind of estimates.
I have a question, and it gets to the issue of what proportion of greenhouse gases in the United States are attributable to our healthcare industry. You estimated that worldwide it's 4%, and the United States accounts for 27%, so maybe 1% of the international total. That's a little lower than I would have expected. We are almost 20% of the gross domestic product of the United States, which is the largest economy in the world. If just as a proportion, I don't know what proportion the United States accounts for in all sectors of greenhouse gases. Do you have that number?
In rough terms, there's been some studies that have looked just at the U.S. hospitals, and they came up with a figure of 10% of U.S.
10% of U.S. emissions.
Of U.S. emissions. And so that would be, so another way to think about it, in addition to the proportionality of the United States, is if American hospitals were a country, they would be around 13th or 14th in global emissions. They'd be ahead of Great Britain as a country.
Just hospitals.
Just hospitals.
But of course,
it's much bigger than that.
Not just hospitals, the healthcare sector. Hospitals make up about over a third of.
So 10% is the total for the healthcare sector?
As much as we know.
In the U.S.
In the U.S.
The study for that was a Sherman and Eckelman study from 2016, and we're happy to share that.
The U.S. is 15% of the world's emissions.
So 10% of 15% would be about 1.5%. Okay. All right.
I mean, the other thing to say is, David, is that it's not just the health sector. It's that once you leverage the health sector around other parts of the economy, then it pulls in other things. So, for example, one of the strategies is to work with hospitals and schools and universities and municipalities to drive the market for more low carbon forms of agriculture, more responsible ways of doing meat production. And so that has a broader knock-on effect. There's all sorts of efforts in the supply chain now, not only in healthcare, but in other parts of the economy to reduce single-use plastics, which becomes another sink for fossil fuel expansion. So there's sort of a part of the strategy is to leverage the economic clout of healthcare to have a broader impact than just its own operations and its own supply chain.
And the 10% figure includes those supplies or not?
Jessica, how much do we know about that?
Yes, it does.
Okay, great.
We have another question from Dr. Neil Kalman.
So I just wanted to, I think you guys probably used the term hospital about 100 times in the presentation. And I represent a network of community health centers. And there are about 8,000 of us across the country, 8,000 community health center sites. Two things about them. One is, we know that a lot of the pollution and stuff like that is centered in low-income neighborhoods, whether they become low-income because of the pollution and nobody else wants to live there, or whether we cite things in those neighborhoods because they're the least politically powerful. This is something that's clearly an issue. And the community health centers are very much oriented towards their communities and towards looking at this. So there's been lots of discussions amongst community health centers about how to deal with environmental issues. So I'm just wondering if you've reached out to them as part of this movement, both as an organization. There are powerful statewide organizations of community health centers and others. I know that people would be interested if that could become an additional focus for your efforts.
I appreciate that, Neil. We've done some outreach to community health centers, and as more and more of there's consolidation in the healthcare sector where the large hospital systems are buying up ambulatory and community health centers, a number of those are sort of getting brought into our network. We not enough though. So I mean, it's a great invitation. And in the end of the day, I think as healthcare moves out of acute care hospitals, hopefully, into the community where resilience can reside and where prevention can reside, I think community health centers are going to become even more important as those anchors in those communities. So I welcome the opportunity to work with you to expand.
Okay. Our next speaker is Robert Bonner. I'm not sure I pronounced that.
We also have a question from Melinda.
Melinda, is this a point of clarification?
It is not a point of clarification. I can hold it till the end.
Okay. Mr. Bonner, is that pronounced correctly?
Bonner, yes.
Okay. Thank you for joining us.
Thank you for inviting me. As was mentioned, my name is Bob Bonar. I am the director of the Master of Healthcare Administration residential degree program at the George Washington University. But the project about which I'd like to speak with you today occurred while I was the chief executive officer of the Children's Hospital in Austin, ultimately to become Dell Children's Medical Center in Central Texas. That particular project was the first U.S. green building LEED Platinum hospital in the world. We began design on it in January of 2003 and moved into it on June 30th of 2007. We actually started out to obtain gold designation, but as it turned out, a major problem we ran into turned into be a major blessing. We weren't very far into the program, and Austin Energy came to us and said, we don't have enough power to supply your hospital. And I said, well, that's a problem. So we came back around later on, and I'll talk about that in a little bit. In order to solve that problem, we went from gold to platinum. An early problem additionally was determining the incremental cost, and actually basically selling it to our board. That hospital and the system in Austin is part of Ascension Health. I was happy to see their insignia early on there in this effort. And our architects and design engineers estimated that it would be about $6 million incremental cost to build a green hospital, but that the payback was in 6 to 8 years. So if you look at the useful lifespan of a hospital, we thought that was a reasonable risk to take. So the board bought off on that, although I must tell you, my immediate supervisor at Ascension said, Bob, remember, to whom much is given, much is expected. So I kept that in mind when we started operating the place. The process itself was fairly typical. We had a design team at the executive level and then unit departmental planning committees, but we made some internal rules on that. And one of the big ones was no plans would go to contract documents unless the medical directors and the nursing directors of those areas signed off on them. So we wanted to build a hospital, so when we moved into it, we didn't have our medical and nursing staff saying, who was the crazy person who designed this? So we avoided that. We were encouraged to blue sky and be creative. However, all green building components were controlled at the design team level. So, you know, early on, one of the design elements was going to be, we were going to have windmills on top of the hospital and so forth. But the determination was made by the engineers that technology was not yet advanced enough to be useful and reliable in, you know, providing energy to a hospital. So we eliminated it. We also agreed that we're going to be no upgrades and no changes, no change orders were permitted unless they were on an ad alternate list that the executive team had approved, and they were covered by philanthropy, because I was determined to bring this thing in on time. And my major role on the committee, since I'm not an architect, I'm not an engineer, was to ask how much does that cost and to sit there and wring my hands at these meetings. But we did bring the project in on time, actually, and about 1.2 million under budget. Just real quickly, I'd like to run over some of the major features of the building before we get into the study that we did, which concluded and published in 2014. The building at that time was 500,000 square feet, although it's much bigger than that now because they've added a third bed tower. It had a double helicopter pad. There were 2 initial bed towers, 3 floors, 3 pods per floor, 8 beds per pod. So we opened it with 174 beds, which included the newborn ICU, which was in a different section of the building. The planned footprint for a third bed tower, which required minimum excavation, was literally built into the landscaping so it could be built with minimal cost to site preparation. The building had 6 enclosed healing gardens so that virtually every room and about every office, with a few exceptions, had an outside view. It included a large 4-story space. The terrace had a 4-story waterfall with a lagoon at the bottom right outside the cafeteria patio. It was a level 1 pediatric trauma center for 46 counties in Central Texas. And of course included a NICU, PICU, a rehab unit with a rehab pool and so forth. We sold adjacent land to our affiliated physicians, and they used it to build an ambulatory building and a joint venture outpatient surgery center, which was very actually successful. And that strategy was to get the minor commodity cases out of the hospital over into the ambulatory building, let the physicians enjoy that revenue. And we were able to utilize the inpatient space for rooms for tertiary and quaternary care. We utilized all sustainable building products such as glues, wood walls that were allowable by code. That created a few problems with getting the linoleum to actually stick, but we redid it until we got it right. Since Austin has 300 sunny days a year, and many of those days exceed 100 degrees, that hospital had actually 4 different types of window glass in it, depending on whether it was north, south, east, or west exposure. You couldn't tell it from the outside, but each was designed to filter out as much heat as possible, but allow in the light. A lot of these things, you have to remember in 2003 when we were designing this, these were sort of new. These things have become more common over the years. Light sensors were in all the hallways as well as offices. In call rooms, we learned to turn them off in the call rooms because every time the physician on call turned over in bed, the lights came on. So just little bugs that we figured out we had to fix. The air intakes, remember this was not too far after 9/11, so the air intakes were all, the HVAC air came in the bottom of the locked healing gardens. That saved a lot of energy because we were pulling cool air in instead of hot air off the roof. And it also kept anybody from wanting to cause mischief to be able to put any biologicals into the HVAC system. Now the energy plant was what helped us go from gold to platinum. And I've always, you know, the old saying, I'd rather be lucky than good, but it's nice if you're both. The solution to getting energy there was to build our own on-site cogen underground gas supplied generating plant, which had a black start diesel generator as an emergency backup. And then our third backup was actually the power grid from Austin Energy. We then sold Austin Energy that power plant, and they operated it for us and guaranteed the hospital system power at the tariff rate in perpetuity, and they were allowed to sell any excess energy generated there. And it did generate more energy than the hospital needed. It also served as a source of our steam generation and so forth in the winter for heat. Now the big question was, after we got this thing, and by the way, we saved a lot of energy because we were transferring that energy 200 feet, not 25 miles from a coal-fired power plant someplace. So that was a big issue for the green building. The question was, did it work? Was it worth it? Our conclusions were, after 7 years of study, in a word, was yes. Our first 3 months were horrendous. We were not meeting our energy goals because the building wasn't properly HVAC balanced. So I would go down to the doctor's parking garage and there was so much cold air coming out, you couldn't get the doors closed. So we worked on it for 3 months, the engineers did, and by the time we got it where we needed to be, it was hitting our energy consumption goals quite well. But one of the things that I would like to lift up here today that we found that I think is often underestimated to some extent is the human aspect of sustainable building design. Now, we were bound and determined to try to prove to the board that the money we spent was wisely spent. So we commissioned a research study using, as much as it hurt me to do so, I had to use the Texas A&M engineer.
No.
But we published that study on March the 4th of 2014. It was entitled Return on Investment of a Lead Platinum Hospital. And it compared the influence of sustainable building design on employees in the hospital environment. And we focused on employee engagement, satisfaction, well-being, and the perceived quality of the indoor environment. Now, the main objectives of the sustainable design that we had set out from the beginning were to avoid resource depletion of energy, water, and raw materials, prevent environmental degradation, and create built environments that were livable and comfortable, test the tenets of sustainable building design and its impact on environmental, social, and economic factors. So the study focused on social outcomes for healthcare workers and related economic implications influenced by hospital facility environments, not so much on the energy component, because we were comfortable that we had already shown beyond a reasonable doubt that we were hitting our energy targets. And we compared our hospital to other hospitals in that Ascension system that were located in the Austin area that had a similar environmental circumstances in terms of heat and cold and so forth that the Children's Hospital was in. And that included 2 hospitals that were actually newer, that had been built in the interim than the Children's Hospital, but not built to LEED standards. So here are the findings of the study that took place over that approximate 7-year period. The first thing we found was that the employees at Dell Children's were more likely to agree that the indoor environment reflected better the mission of Ascension Health. You might not, I was actually skeptical of that, but it did make a difference to employees. In terms of the temperature being comfortable, the sound levels being sufficiently lower, which was a terrible problem in the old hospital with the racetrack design units, and the air quality being healthier. On average, we found that employee turnover rate for the Children's Hospital was 3.57% lower than the national average. That came from NSI Nursing Solutions, a study in 2012. Third, we compared the old Children's Hospital turnover to new hospital. In terms of comparing ourselves against ourselves in the old hospital, we were actually 6.5% lower in the new hospital as compared to the old hospital. And that is very significant when you think about what it costs to replace employees, in particular nurses. At that time, the nursing journals indicated that the average turnover cost for an RN was roughly $80,000 in terms of training, replacement, and orientation costs. I'll come back to that total savings later on. We also found that the rate of on-the-job injuries was significantly lower at the new LEED Children's Hospital as compared to other hospitals in the study. And the calculated estimates in the literature of the direct and indirect costs of every on-the-job injury, if it's bad enough to require days away from work site, was $70,000 per case. So, you know, at that time and up to that time, the value of sustainable building design for healthcare facilities had been sort of mixed. But there is evidence that the reduction of energy and water consumption does reduce the operating cost. But the variable that we assert is often overlooked, and we think it bears out in the study, is that impact on the indoor environment on employee engagement and the perceptions of employee health and well-being and the impact on turnover. So our study showed a 5% increase for employee engagement, a 5% increase for health and well-being, a 4% decrease in the frequency of undesirable health outcomes on our staff, such as exhaustion and susceptibility to illness, and a significant reduction in turnover rates indicated that the hospital has been reducing costs related to turnover, recruitment, and retention. So the estimates that The study indicated that during the period from 2007 to 2014, the period of time which the study involved, the hospital saved $4.5 million just for reduction of turnover alone across the board, across all employees. And that did not include the costs of reduction in use of electricity, water, and so on and so forth. So that is my report, and I'll be happy to try to field any questions. I have a copy of the document here, but it's not real interesting reading, but I can supply it for you if you would like.
Great. Any questions that are points of clarification? We'll come back to the general topic of climate change and the healthcare system and questions that are more about tactics and policy and ways to move forward. But any points of information that anyone would like to clarify? Okay, thank you very much, Bob. I'm sure we'll be back to you. I think next is Tom Doherty.
All right, thanks a lot. Hey, I really appreciate these talks. They're really inspiring. I'm going to go ahead and share my screen. And you all should see my title slide. Yeah, so I'm speaking from Portland, Oregon. I'm a clinical psychologist, and my perspective is as a clinical psychologist and a healthcare provider with experience in private practice. I've also done work in outdoor therapy. I'm also experienced in broader academic environmental psychology, and actually did my dissertation in working in a cardiac rehab unit. So I do have some experience working in hospital settings as well. And I've been tasked with talking about psychology, the role of psychology in responses to climate change in the healthcare system. Obviously a big topic, and I just wanted to touch on a few strands of this, which I think will echo what the speakers have already been discussing, which is good. I wanted to talk about some areas of psychology that are helpful for addressing climate change broadly and in healthcare, just to make sure people are aware of the resources out there. I wanted to talk a bit about some of the thinking styles and the mental models in healthcare that might frame consideration of addressing global climate change in a healthcare setting or in a community health setting. I'll pull back a little bit and just talk a bit about my research on the mental health impacts of climate change more broadly, just to situate our talk. I'll echo some of the points on nature and green spaces in healthcare and how they benefit patients, providers, and the community. Maybe extend those comments a bit, and then talk a bit about just some behavioral strategies to promote change in the hospitals and healthcare settings. Some of this may be familiar to you, but it's important to think about psychology broadly as a field. There's a lot of resources to draw on regarding climate change or addressing climate change mitigation or adaptation in healthcare. We have clinical and environmental psychology work that has specifically studied climate change impacts broadly, which I'll talk about a bit later, and also general stress and eco-anxiety in the community level. Obviously, health psychology is active in healthcare, and there's a ton of great research, very robust research on the benefits of green spaces in healthcare, window views, things like that. Obviously, we're talking about organizational change, so there's a lot of resources broadly in organizational psychology that we can draw on to really link, as has been talked about with the previous speakers, link some of these efforts to the organizational identity, to the goals of the employees and the staff, and addressing internal politics as these changes roll through. And then at the point of behavior, there's a lot of interesting information about how to actually reinforce the new behaviors, and I'll talk a bit about that as well and give one example of that. I thought about how we might frame climate action for different subcultures in healthcare, and I think this is interesting as we think about how to apply this. I think this is simplified, obviously, but obviously in healthcare, we're going to have some folks that are going to be working from a fairly strict medical psychiatric model. And I think we want to focus on the health outcomes for patients and the quantitative research and evidence-based approaches. There's going to be folks in the healthcare system that are really working in an interdisciplinary level that is moving, more to a biopsychosocial approach, or moving beyond just an allopathic sort of approach to think about combining fields, bringing in social science. There's a robust field of horticultural therapy, for example, that works in hospital settings. So using green spaces and plants and gardening as part of medical care. There's a professional organization for this group. They have national conferences, and they would be an ally in this kind of work. And as has been talked about, the modern hospitals are really transforming themselves from kind of sterile places to really open air places with gardens and things like that. And then hospitals can be a center for working on public health, broader public health and global health outcomes. And then we'll have another culture in hospitals, hospital settings and healthcare settings that, of folks that are working for more of a complementary or alternative approach to health that may be more holistically focused. And I think we want to look at the qualitative outcomes for physical and mental health, patients and communities' cultural and spiritual needs, their lived experience, positive emotions, well-being. And again, this is being, I'm echoing what some of the speakers have been talking about. But I think we want to meet people where they're at and be aware that there's going to be diversity in the internal stakeholders in these healthcare systems. For all of these areas, diversity and social justice is important. All environmental issues are primarily have a social justice impact universally. Whatever environmental issue you want to consider, including climate change, that it's disproportionately, impacts are disproportionately visited on those of least power and privilege, both in my community of Portland, Oregon, and Oregon State, and the United States, and worldwide. So we really need to lead. I think in this discussion, we need to get that diversity and environmental justice message out first, because if we miss that, people will lose trust in these interventions, particularly in communities that are diverse in a range of socioeconomic groups. I'm going to just step back to more of a 20,000 foot level and just think about the mental health impacts of climate change broadly. And this is based on my research and other folks' research. When we think about climate change globally, we can think about the three broad areas of mental health impacts. The first area is fairly obvious to people. It's disasters. It's the direct and acute impacts. It's the environmental disasters, extreme weather, droughts, fires, etc. There's a robust field of disaster psychology, and people have studied how to intervene in natural and technological disasters, and how to provide psychological first aid, and how to address and track psychological trauma. And certainly climate change is increasing events, extreme weather events, and various other problems. And this, of course, blends with other modern problems in terms of population and globalization and things like that. Of course, we're seeing a variation on this with the COVID pandemic. A second broad category of impacts with climate change is, the broad ripple effect impacts that come from disasters that last in the weeks and the months and the years after disasters, and how things like droughts and fires and other climate change impacts cause migrations and refugees, and increase intergroup conflict, and lead to wars and various things like that. So we have broad public health ripple effect impacts to think about. And then there's indirect impacts of climate change. Those are the psychological impacts of just bearing the weight of climate change, dealing with troubling climate change imagery, sitting with the injustice, sitting with the problems, dealing with the political gridlock, etc. So when we're thinking about healthcare, we can start to think about these broad levels. So we might think about how healthcare systems are really, poised, as speakers have talked about, to be the last building standing, and to be a center of health and resilience in disasters. We can also think about the healthcare centers as hubs for broader community health and thriving and public health goals. And then we can also think about these systems as centers, maybe an oasis for mental health and well-being, and how we can extend, wellness and well-being throughout the community. And when we chat later, we can get in more into the finer points of this research. But people's ideas about climate change are mediated by their existing beliefs and their media images and things like that, and their impacts are moderated. Some communities are better placed to be resilient than others. So it's fascinating stuff. This has been talked about, but I've got some experience in this idea of green spaces in healthcare, and I just wanted to kind of run through this a little bit. The public is well aware of the healing power of nature and the benefits of green spaces and getting outdoors and things like this in terms of stress reduction and mental restoration, living cultural values, things like that. So we're really well positioned now. And although, like our previous speaker talked about this fascinating hospital, I want to when we think about nature benefits, we want to realize these are on a spectrum from indoors, plants in rooms, window views, passive, imagery of nature. And then we move into more outdoors, into local spaces, green spaces, parks, gardens, movement, walking and things like that. And then we move on a spectrum more to more active activities in more wild spaces. So we can think of, healthcare as trying to either exhibit these qualities, promote them in the community, or be hubs where people might move out from the hospital to do more active or more far-ranging activities. And so we can think of these modern hospitals, with their gardens and access to outdoors and window views, as really being, healing places. And as many of you know, the first research on this came from, the research on window views, and that, surgery patients would recover quicker with green window views, and that sparked this whole movement. So it came from a very empirical, very outcome focused approach, and has then been built on over the last few decades. And then we also can talk about the architectural aspects of healthcare buildings and settings for the patients, for the workers, in terms of being healthy living buildings with natural light and fresh air and places for movement. And then we can use our spaces around the healthcare settings for healing, and actively use the gardens, horticultural therapy and things like this. And then we might move out into the community in terms of promoting exercise in the community, addressing healthy diet, addressing food deserts in marginalized communities, working with community gardens and green spaces, adding gardens and outdoor spaces in criminal justice settings and things like this. So I do think healthcare settings can be a hub for many things. And they can be empowering to the community too. So we can sort of think about the leadership role has been talked about. And just some points on organizational change. Fascinating stuff here. When we step back, we realize there's three broad value sets that drive people's environmental concerns. Egoistic concern with our own self, our family, our personal outcomes. We have other folks that are driven by altruistic values, helping others, and we have others that are primarily driven by biocentric and earth-based values, ecology, and more of humans as one part of a natural system. And obviously, we all have our specific, pattern of these values. But when we do get with people, I find it really interesting to talk about groups and just where they come at their environmental concern, and that's a great base to talk with folks. And then when we're doing behavior change in a setting, there's a number of tools that come out of psychology. We can try to make the behaviors more easier. We can give people information and education. We can give them more feedback and rewards at the point of behavior. We can look at social modeling and kind of social psychology processes. And then these can be kind of applied based on what we're trying to do in a setting. For example, if the benefits to the individual of doing the behavior are low personally, and the barriers are high, it's unlikely for them to do a new behavior unless we incentivize it. If something is really beneficial for the person, but there's a lot of barriers to them to do it, we need to make it easier, right? And if something is really helpful to the person and there's low barriers, we just need to educate them about that and remind them about the behavior, so that we can get into the really fine points of how to roll out behavioral interventions. And just an example of this isn't specifically around healthcare, but just to give you an example, I was working with some folks at the Portland airport in the sustainability program there, and they were trying to increase, Portland airport's quite forward thinking on all sorts of sustainability factors, but they were trying to increase this idea of sorting of food waste to get it out of the waste stream. And they were thinking of doing some end of the year contest to give someone a vacation trip if they just, food businesses would do this food waste. And I suggested that they actually intervene at the point of behavior. So to try to recognize the food service employees when they were actually sorting the food waste in the restaurant. So they created this sort and win contest where they gave people just some really inexpensive gift cards when they witnessed them doing the sorting. But this was a super success, and it increased their food waste collection about almost 60%, versus the previous year. And so it was just a good example of how, when you're savvy about behavior change, you can make a big difference in your settings. And that's a great place for psychology to contribute. And that's a broad survey of things, but that's my comments for today, and I hope that's helpful.
Great, thank you very much. Points of clarification, questions of clarification? Okay. So we'll now go on to our last speaker in this panel session, and that's Mr. Vernon, Walter Vernon.
Okay, well, thank you guys for inviting all of us to speak with you here today, because I actually believe the world needs you to respond to the climate crisis. Gary talked a little bit about natural gas research, and I'm a buildings guy. We can certainly talk about natural gas all day long if you want to, but I'm actually going to take a somewhat different tack today. And I'm going to talk a little bit about narratives and the power of narratives. I am in the building environment. I've got a bunch of offices across the US, and we're working with healthcare clients every day, trying to help them plan, design, build buildings. And we run into all kinds of dynamics in doing that. And this takes the form typically of certain kinds of narratives and stories that I think are endemic, and I think that need to be changed and evolved. And I think you guys, you did that, right, with to err is human, and I think you have the power to do it again. I do want to pick up on a point that we were talking about a little bit earlier when we were talking about metrics, and we were talking about the impact of the hospitals or the health sector in terms of buildings or the health sector broadly. A number of years ago, one of the pioneering efforts in this idea of measuring the impact of the healthcare sector came out of the UK, where the NHS tried to measure its greenhouse gas emissions as a sector. And the buildings only constituted, I think, less than 25% of the total impact of the health sector. Really, transportation was about another quarter, and procurement in a broad sense was really more than half of the footprint. And so while it's really tempting to think about green buildings and energy of buildings, and I'll talk about that a little bit because that's my field, I think much of the opportunity lies at other scales. And I'll just tell you a quick story about that. I do a lot of work with Kaiser Permanente here on the West Coast. And in the early days of telemedicine, Kaiser rolled out some telemedicine programs, and they discovered that when they did that, obviously primary care visits dropped, and when primary care visits dropped, hospitalizations dropped, and utilization across the system dropped, and yet they were able to maintain, at a covered lives perspective, similar outcomes. And so the need for buildings, by changing how we delivered medicine, eliminated some need for buildings. And the greenest building that ever gets built, of course, is not the one that's more efficient, it's the one that never gets built. So I think, you know, as you think about where to put your finger on the scale, I think we need to think about healthcare in a broad sense, as well as what happens at the scale of the building, whether it's a hospital or a community health center, obviously. All right, so I guess what I want to do is tell you 3 stories, each of which I hope will illustrate a narrative that is in the world of healthcare planners, designers, builders, and that I think you have the power to help change. So I'll start with my home state of California. California, you know, I think is rightly held up as a model of environmental performance in many respects. We have some obviously aggressive energy policies in this state. We're very proud of the fact that if you look at our emissions per person, we've been flat for the last 30 or 40 years, whereas our GDP for the state has gone up, thus, in our view, proving the point that you don't need to pollute to prosper. And that's all great. But through an administrative error, really, hospitals in the state of California have never been subject to any energy regulation, actually just this year. And I was several years ago working with the California Energy Commission trying to move California to start to regulate hospital energy systems. And I was in a meeting with one of the high-placed people in the state licensing, health licensing board, and we were talking about this, and he said, "Well, are you kidding me? Do you really mean to tell me that you're willing to let your mother die on the operating room table because you want to put in a little bit more energy efficient light bulbs in the OR?" And I was sort of taken aback by that. And I wish that were an exaggeration or a joke, but you know, it is, he was very serious. And that is an attitude that is still out there. The narrative being that there is, you know, I think in some ways it goes back to Jimmy Carter wearing a sweater, right? And telling us turn down the thermostats and creating the idea that if we want to protect the environment, it means we must sacrifice. And I think there is still this narrative, and I think it is endemic in many ways in healthcare that there is a necessary conflict between environmental performance and patient care. And I think that's a narrative that we have the power to change and we need to change. The second story that I want to tell you is about another policy organization that I do work with. This particular organization is one I'm sure you've never heard of, but it writes documents that form the model licensing code for healthcare facilities, whether it's hospitals or ambulatory care or residential across the entire country. So it's hugely influential. This particular organization works on a 4-year cycle, and every 4 years they update their standards, and then the states all adopt them or some version of them. And every 4 years, for about the last 20 years, I've been working on this, and I would go often with Gary and some of Gary's folks, right? We would go to this group and we would say, listen, let's put in some very minimal environmental performance requirements, just, you know, just the most basic things, right, into building requirements. And every 4 years they shoot us down and we resolve to try again the next cycle. And every 4 years, what they tell me is, no, it's our job to think about patient care. It's our job to think about healthcare. It's not our job to think about the environment. And that, I think, is another narrative that I find a lot in healthcare systems. And there are those champions that Gary talked about, certainly. But there's a large segment of the healthcare leadership that needs a different narrative. You know, I was working with one of the healthcare systems on Gary's slides yesterday on an energy reduction project. This particular organization has won tons of awards, but the vast majority of its buildings are actually very poor performers on an energy scale. and they're trying to figure out how to do better. And the narrative that they hear is, it only works if we can show rapid financial payback. And very often, sometimes it is possible. There's no question that sometimes it is possible. But the reality is it's very often more difficult than that. And it is, I think we need a new narrative, that it is healthcare's job to care about this and not just to care about taking care of the patients inside. And I think that's a narrative that needs to change. The last story that I'm going to talk to you about is a different policy organization I work with. I do a lot of work, I should have started here maybe, in terms of research around how can we do better in our buildings? How can we use better systems? How can we create new technologies, deploy them and do better? And then trying to move those into policy, and then trying to move clients to actually do something and implement them. Because one of the things I've learned over time is, research by itself or policy by itself or implementation by itself, none of those is the silver bullet. The silver bullet really is all three of those in concert, working together. And that, I think, is the place where narrative matters and where you have a place to play. This third organization that I'm going to talk about creates a lot of the ventilation standards, the heating and cooling standards for the whole world, but also for healthcare in particular. And it's a really interesting group, right? They're a group of self-appointed, somewhat self-interested experts. And what they're experts in is designing their systems. They are not experts in research and evidence and how to apply research and evidence. I'm doing a project right now with Academy Health, who I'm sure you know. In fact, some of you I saw are actually on our Academy Health team, where we're actually looking at the process of how health services research is taken from conception to team formation, to funding, to performance, to policy, to implementation. And it's really interesting. I was listening to your thing this morning about opioids and clinical guidelines. And I think there are such parallels in how you're structuring clinical guidelines and how we ought to be doing that in the built environment. And instead, our narrative is that the experts who know how to design these systems are the right people to be making decisions about what the rules ought to be. And in the last couple of weeks, of course, in the shadow of this COVID crisis, one of the things I've watched is this group of ventilation experts who are looking at what is the path of transmission of COVID, right? And there was a study that came out of the University of Nebraska that found some RNA in a corridor outside of an active patient. And so this particular group has decided, therefore, it must be that the transmission is airborne, and therefore it must be that we're going to mandate expensive energy-consuming systems because we cannot tolerate any risk, right? We're in a way convinced by the idea of an intolerance to risk for the patients in the buildings. And so the narrative is, that needs to change, I think, that a group of self-interested experts without real effective process is the right way to make policy that's going to impact us, because this particular decision will change the energy performance of buildings, of hospital buildings, healthcare buildings across this country in ways that will impact the environment. So we could talk about all kinds of things, and I'm happy to talk about natural gas, green buildings, or any of the other things. But I do think these, given who you are in the world and the stage that you have to change the narratives, give people like me the ability to then work with decision makers to make better things happen, whether it's at the level of research or policy or implementation. I think that's what the world needs from you is reframing these narratives. We've got to get away from the idea that there's an inherent conflict between delivering healthcare and protecting the environment. We have to get beyond the narrative that it's not our job to worry about the environment, it's our job to worry about the patient. We've got to get beyond the narrative that says it's okay for some, I think, narrowly focused, we'll use that term, experts to be making decisions really in an uneducated kind of way, not taking into account the full impact of those decisions. I think we've got to get past that. And you know, 20 years ago, you guys did that with The Air is Human. You set a new paradigm for how we think about patient safety in this world. I think you have the power to set a new narrative now. And the climate scientists are telling us, right, we have 10 years to bend this curve. I think if not you, who, and if not now, when?
Great, thank you. Thanks to all our speakers. These are a series of arguments that many of us in the healthcare world don't hear all that often, so it's very provocative, and we're open now for any kind of question.
We have a comment from Gary Cohen in the chat box. It says the NHS has committed to zero emissions for their entire system. Telemedicine and telework are components of this strategy. They thought it would take about 5 years to change the healthcare culture to accept telemedicine. In the COVID crisis, they were able to achieve this transition in 3 weeks.
So, never let a crisis go to waste.
Exactly. And some of the other hospital systems in New York and elsewhere are also using this crisis and obviously the danger of bringing people to the hospital to do telemedicine and telework. And so that's accelerating. I think what the COVID crisis is showing us in so many different ways is that we can speed up the behavioral change that Thomas was talking about in moments of crisis, and the very kinds of interventions that we need to make, and the understanding of the vulnerability of the community and the supply chains that we have, all those same concerns that we have around COVID, we can match those to climate. And so it's very, very important to understand the lessons of this crisis.
Okay.
David, I just want to point out that we have 2 other National Academies board directors with us now, and maybe we could just have them introduce themselves very briefly.
I was just going to mention that. Please, these are members of boards from other sections of the National Academy of Sciences. There's a National Academy of Sciences, National Academy of Engineering, and the National Academy of Medicine are all sister institutions.
John, do you want to go first?
Yeah, sure. Hey, I'm John Holmes. I direct the Energy Board at the National Academies. And the link-in that we're doing with this activity, as well as I'm running something called the Deep Decarbonization Initiative at the Academy. It's a cross look at mitigation approaches, especially accelerating them over the next 5 to 20 years. What we're going to look at is a very broad element of carbon mitigation, of emissions mitigations in the United States. We won't go that deep into the medicine sector, and that's where this activity and what we hope to do with Sharon will help us out. There's a lot of activity going on in this arena, and it's nice to have the link into your group. And a lot of it is in buildings, and that's where we have Cameron.
Hi, I'm Cameron Osvig. I'm the director of the board on infrastructure. And similar to what you described, our activities are focused in the built environment and mainly buildings, not so much in healthcare. And so that's the tie-in here. Although we have done some work with green healthcare and sustainable design. We're mostly focused in building energy use, deep energy retrofitting, and resilience and hardening of infrastructure are some of the areas that were discussed today that my board looks at. We've recently done some studies with the VA and with the NIH, though, which have given us a greater foothold in the healthcare areas.
looks like Andy has his hand raised.
Hi, thanks for the great presentations. Really enjoyed them. One thing I was intrigued with in both what you said as well as the background materials that were prepared, you use this term resilience, and you talk about the degree to which the healthcare system needs to be resilient related to climate change. I think the same term is kind of emerging related to COVID-19 and sort of the degree to which the healthcare system has resilience in a different kind of way. And I'm just wondering if you think that kind of nomenclature is helpful more broadly, and whether there's a way to sort of embed the way you're thinking about resilience for climate change fits into an even larger way of thinking about resilience for the healthcare system, and whether your own reflections on using that term in the immediacy of what's going on with COVID-19 has given you a slightly larger, frame around that. When I'm thinking about some of the resilience that we need now, it's flexibility in our workforce. Someone already alluded to the flexibility of switching to telehealth, flexibility to think about how to share or distribute resources to, wherever the front lines might be dealing with an epidemic. So anyway, I'm just intrigued with this notion of resilience. Wonder how much you have found it helpful as a way to talk about seeing a future, and if it might be take on even a broader point of view given the way we've been challenged in the last few weeks.
This is Gary, I'll start. I mean, I really appreciate what you're saying, Andrew. It's exactly what our organization is sort of moving toward, is moving to starting with healthcare's resilience, because that's our focus, and making sure that they can operate and their supply chains work, especially in times of crisis, and people can get to work or not get to work. So there's a whole element of building and all that resilience. But the big idea here is, I think, embedding healthcare, whether it's community clinics or hospitals, or within a broader community resilience frame. And so, if people don't have good food, or food insecurity, if people don't have jobs, if people have crappy housing or insecure housing, they're going to be sick. So we have to see these, if they're living in polluted air areas, they're going to be more vulnerable to COVID. There's been studies that have come out that said if your respiratory issues and air pollution have a very high correlation with increased mortality to COVID. So if we can see healthcare as using its workforce development, its investments, its community benefit, its community health, its procurement, as helping to partner in a broader community resilience frame around energy systems. So not just invest in renewables for your own facility, but for the community. That's what Gunderson Health System did in Wisconsin. They co-invested with other partners in the community. Not just investing in food systems to bring food to your own institutions, but investing in food for the community. To build that kind of reweaving of systems that design in resilience, to move their workforce development to address racial inequities and redlining that's been true in so many communities around America, so that they're providing more jobs to people in the community. There's so many ways that we can re-envision the role of healthcare going forward now that's way beyond individual care toward much more of a broad ecosystem community wellness strategy. And resilience is at the heart of it.
Yeah, if I could offer two other thoughts about the issue of resilience, and this comes in some ways from the perspective of people who are designing buildings. In some ways, I do want to echo what Gary said about thinking about resilience more at a societal or community level, and a little bit less at or maybe the health system level, I suppose would be a way to say it, and less at a building level. As we deal with people who are investing capital into the built environment, the issue of resilience has in many, to many people, a direct benefit to the people who are building a building because it deals with what they're doing. Whereas when I talk with people about climate mitigation, the impact is much more diffuse and much more external. And the idea of hardening a building is a more attractive idea often than the idea of investing in mitigation. And so there is, there are strategies that do both. And of course, that's the silver bullet, to the degree that there is one. And that's where we try to focus. But it's wildly imperfect in the real world. And I think there is, so there is a challenge potentially there that we just have to be aware of. And the other thing that I have found over time, I'll just give you one other little example. I have now been, I feel a little bit like a storm chaser. I've been running around the country deploying electrical meters in hospitals that are going through COVID surges because we're rethinking how we size electrical components in healthcare buildings. And I work with a group of people, another group of code writers, and part of the attitude is, right now we require systems that are about 10 times bigger than what is needed on a day-to-day basis. And that's a lot of copper, a lot of components, a lot of generator, a lot of diesel fuel that have to get consumed. And when I argue with people about why do we need things that are 10 times bigger than they need to be, the argument often is, well, it's because we have to be ready. We have to be ready for the surge, right? We have to be ready for that. And I sometimes wonder about the value of investing in hardening every single building all over the country versus a different framework for thinking about system resilience rather than building resilience. And so I think there's a lot to unpack in the resilience idea. And I totally agree with Gary. It's a place it's a magic opportunity. So yes, great question.
We have a question from David.
I have a whole, thank you for your presentations. I have a whole bunch of questions. But let me start with the one that I think is, I found, one of the many I found interesting, and that was the Austin Children's example seemed to suggest that there was about a 5, 6, 7 year payoff to the investments that were made in making a green hospital. I'm not sure I heard that quite right. I heard somebody else, maybe it was Walt Mazzetti, Walt Vernon, not Walt Vernon, well, I'm not sure if I heard say it, that the ROI wasn't quite as clear. So I think this is a really critical issue for the healthcare sector because in my experience as a healthcare manager, the dominant voice in healthcare institutions is the CFO. And if you can't make a financial case, you won't get out of the box. So it's wonderful to talk about doing the right thing and doing good and all the ways in which healthcare institutions are responsible for their communities and ought to be doing things differently. And there are some institutions, and Ascension, I see David Pryor leaning back there in his chair. I see Ascension and a few others, Kaiser, really do things because they're the right things to do. But it really helps to make it easy to do the right thing. So what can we say with confidence about the return on investment from greening buildings or greening supply chains or doing the other things that are likely to reduce CO2 emissions? And I'm not talking about societal ROI, because frankly, that doesn't matter to CFOs. I'm talking about the financial report for the next year and the next 5 years.
Could I lean in on that one a little bit?
Sure.
I think I agree with you. That's why I had someone from the finance office on our executive planning team. because I knew we had to meet those, the hurdle rate. I mean, we had to do that. That's why we ran numbers again and again and again. And Ascension took a chance on us. And they said, okay, you guys can do this if you're willing to raise $50 million in philanthropy. And as it turned out, I think this is probably somewhat unique, not entirely to Austin. The green building component was a matter of great interest to a lot of local corporations. We ended up raising $87 million in 3 years. I think that was the largest, at the time, the largest capital campaign that had ever been conducted in Central Texas that wasn't run by the University of Texas at Austin. But I think we proved to a reasonable extent that the payback is real. But I would assert, and I think our study shows, that we underestimated the payback because we were so focused on the dollars involved in operating costs for electricity, water, and so forth, that we didn't give enough attention, and we probably were ignorant enough that we didn't know to give enough attention to what the human resources component was in terms of what we saved by significantly reducing things like employee turnover, especially in our nursing ranks as well. So I agree with you. You have to convince the finance people. The Daughters of Charity used to tell us, Bob, to do good, we must first do well. And I took that to heart. So I think it's possible.
And there's different interventions that have different paybacks, David. So, a number of the hospitals in our network, some of the energy efficiency strategies they implemented, it was an 18-month payback. And then they're making, they're saving $1 million a year on some of these things. Take a simple case of desflurane, which is an anesthetic gas that's used in surgery. It's more expensive than the safer alternatives, and it's 2,000 times more potent than carbon dioxide. So take Providence system, just the Oregon hospitals alone, by moving away from desflurane to safer alternatives that were just as effective in terms of surgeries, they saved $700,000 in 1 year. And so the CFO of Providence said, well, Jesus, we should do it system-wide. So there's all sorts of things that are.
Let me ask a much more pointed question.
Go ahead.
If I wanted to go, I spent a lot of my career at Partners Health System in Boston. We had a very tough CFO. If I wanted to go into his office tomorrow and say, here is the data that proves that we can turn Partners 8 or 10 hospitals green and it'll pay off in X years, where would I go for that information?
We can provide that.
That would convince a green eye shade, tough, no nonsense CFO trained as an accountant.
We could provide that data, and John Meservey from Partners has already provided that data to Partners, and so they've made these commitments themselves to become carbon neutral. They've invested in a wind farm
2050. By 2050. So, I just think it would be great to have that resource readily available for this point of view, or as a resource for any to be confirmed and validated by any National Academy study that went forward.
If I could weigh in here just for a second, because I think the problem is, and I was just been typing away in the chat box, I don't think there's an absolute answer to the question. There are so many variables, and again, I'll just give you one little example about how things have worked in Kaiser. Kaiser has deployed a lot of solar panels and had some notion of how that was impacting their financial bottom line. But because the state of California has now deployed so much solar power, we're restructuring our rates, our electrical rates, and we're changing the time of use charges to essentially eliminate some of the benefits from the solar power systems. And so the economics have changed. right? And so it's really difficult to say that there's an absolute answer to this question. And I will give you one other thought on this particular topic in terms of payback. For years, I tried to get Kaiser to do solar power on their buildings using power purchase agreements, which is a financing mechanism. Couldn't get them to do it, couldn't get them to do it, couldn't get them to do it. There was always this question about payback, right? That's what the facilities people think about. What is payback? And finally, I got to somebody in the Treasury Department at Kaiser, and this guy said, wait a minute, payback? Who thinks about payback? In the finance world, we don't think about payback. We think about impact on net operating margin. And when you look at things in a different financial framework, we can make things make sense that maybe don't make sense in other frameworks. And he ultimately took that project away from facilities and said, you know what? Energy is no longer a facilities issue. Energy is a financial issue, and manage things in a different way. So I just don't think there's an absolute answer to this. I think there are many things that work in many different circumstances, but there are so many variables about weather and electrical rates and gas rates and how you procure, and it is just really difficult to issue absolute statements in this regard.
We also have other hands raised. First, we had Sharon.
Hi, thank you. I wanted to, I like the idea that's been proposed about hospitals as a hub of change, but I worry that that's too narrow because, we all know only 10% of our population's health is due to hospital systems. And I'm wondering if we could really think about broadening it out to more of a public health infrastructure, a public health resilience. I think we started to talk about that, but when we're talking about ROI, because a lot of those health benefits, the reduction in asthma, the work, not days of work not lost, et cetera, are going to accrue at more of a population level. So I think we need to think about those ROIs as well on a broader level, at a state level, for instance, or even the national level. And I know, as we create those models, really to think about it that way more broadly. And I hope we can think about building not only the hospitals, which I think are great, but a public health infrastructure to support this.
Completely agree. Part of some of the philanthropy that is supporting some of this work linking climate and health, I'm thinking of Robert Wood Johnson and the Kresge Foundation. Their framework is, how can you get healthcare to partner with public health and partner with community-based organizations and others in the community to build an ecosystem that is all about a broader public health, community health framework that includes health, it includes jobs, it includes equity, it includes climate resilience, all in a kind of this, Venn diagram of interventions. So I agree.
We also have a question from Dr. Pryor.
Yeah, so I want to come back a little bit to the comment that David was talking about, and maybe Bob, you can react to this a little bit. But I think there's a question of how we look at payback studies and then what's actually convincing to a CFO in terms of the investment. And I think, we can talk about hard green dollars or soft green dollars, or we can talk about the concept of when a CFO is looking at funding a project, if there's going to be investment that's made up front, that individual can look at and say, okay, this is where the payback will come from. This is the budget out of which it will come from, and actually try and build that in. So my question is, where are we really? If we think payback is there, why haven't we seen more adoption and spread? And what is it that we would really need to do in order to try and be clear about that? And is it an all or nothing, or are there particular pieces that we should be starting to look at?
You mind if I lean on that one first? Just thinking about our experiences at Ascension, I think on some level, the way we constructed that whole project gave our finance team maybe a slightly better sense of peacefulness in terms of the use of philanthropy and the refusal to allow any changes in the project unless we had it covered with philanthropy. So we were able to make it, at least to some degree, appear to be and actually be less financially risky. I think that was, and also the other thing was close involvement of the finance team. I mean, you know, we had somebody from the finance team on the executive committee, the planning committee, so they didn't have the sense that something, that we were going to sneak in late at night at the last minute and do something to them while they weren't watching. Was it perfect? In no way, shape, or form was it perfect. But I think if we really go out of our way to involve the finance team, it makes it easier. And the other thing I would say is frankly, just in terms of the future in the post-COVID-19 world, I mean, when I turned 66 years old, I retired from administrative practice. So I came here to teach at George Washington University. So I spend all my time now teaching 24-year-olds how to run hospitals. And if that doesn't scare the daylights out of you, it probably should. But I think we also need to start looking at those 106 CAMI accredited institutions that offer that degree and wonder about whether or not we ought to put some things, at least didactic material in the curriculum in an official sense so that people understand better what we're trying to talk about, what we're suggesting. That would be my take on it, just from my experience. That's the only green building project I've ever been involved in, but I think the way we managed that made a difference to some extent.
Yeah, if I could weigh in as well, I want to give you another example from another healthcare system. We're working with a healthcare system right now that has roughly 50 hospitals across the country. And they're looking at exactly this question. How do we invest in projects and how do we decide where to invest and how much to invest and why to invest in energy reduction projects? And many of these are older hospitals, and they have older building control systems. And a necessary prerequisite, if you will, to being able to implement a lot of the energy saving strategies has to do with simply replacing the building control system that exists. That project in itself will have zero payback. It will be a capital cost. It will enable other projects down the road. And in the energy retrofit business, right, it's very common to try to bundle a project like that with maybe some others that would have more dramatic energy reduction so that the bundle together might have a payback. But in this particular case, they've done a lot of those low-hanging fruit projects already, so some of the bundling isn't there. And again, my only point is, and I don't mean to be a naysayer, I feel like I'm the biggest tree hugger out there, but in the real world of trying to get CFOs, even you can have the closest relationship that you want, but it isn't an absolute thing that these investments in greener buildings always yield a benefit. It can be tough to figure out how to make it work. And I think we have to, though, and have to continue to find ways, but it's hard. And that's why there aren't more who do it.
We have two questions. First is Dr. Terry Fulmer and then Jessica Wolf.
I thank you. This is fascinating and it's inspiring actually, because there's a lot that can happen and it is hard work. I want to go back to Sharon's point about the continuum with public health, and that is, we have done a lot of damage to our public health system, like our nursing home system over the past couple of decades. And we're at a moment where we can address that and people like John Arbach at Trust for America's Health are making enormous inroads. For example, the CDC has bipartisan support to open an aging office to talk about the improvement of care across the care continuum. So I just really want to underscore that. And I will say that Ascension was one of our lead hospitals in our age-friendly health system initiative. And that health system starts at your kitchen table and should get you back there across settings. And so I'm passionate about this, and I think that Sharon's point's well taken, and it's good for all of us, and will lead to some of the savings that we can then put into green. So thank you.
Go ahead.
Okay, I didn't know if you could hear me. I was muted and then unmuted. I just wanted to make a couple of comments back to the resilience and looking at a return on investment or payback. I think that you can't think about mitigation as a separate pillar from resilience. They're really two sides to the same coin. So when you start looking at making a financial argument and you bring in a resilience argument as well, so the impacts of climate change are increasing. I mean, Ascension was hit by the hurricanes and had severe damage to their hospitals on the Gulf Coast in Florida. FEMA and taxpayers had to rebuild some of those hospitals, but it also cost Ascension a tremendous amount of money. The impact on NYU Langone Health and Superstorm Sandy, the impact on Texas Medical Center in Superstorm Allison. These things, if you look at what's needed to make these buildings resilient, to make them be available to provide care and continuity of care through what's going to be increasing and more severe storms, a lot of the changes that you make to make a building more resilient will also make it more efficient. If you use less energy, you can keep going longer. If you put in a black start microgrid, you can go even longer. You can include some of the community in that microgrid, like Boston Medical Center did. They included the emergency communications for Boston in their microgrid. So I think, our paper, and I don't know if it was sent to you in the board packet, Safe Haven in the Storm, protecting lives and margins with climate smart healthcare, it really makes that argument, and it makes it at that CFO level. What are the benefits for investing, and what are the risks of being unprepared? And I think being unprepared is more and more likely each day. And I think it's not just about extreme weather, it's also diseases, as we're seeing with COVID. What happens to the supply chain? What happens as disease burdens shift? And we're dealing with things we haven't before. And the last comment about the aging population, how does our health system have to change to handle the new shifts in the demographics in the population, and to move care out of hospitals? And maybe some of it is shutting down the hospital and looking to the community. We don't want cooling centers in hospitals. Then we have more transportation and more greenhouse gas emissions there. We want them in the community. So I think the person who commented on health system resilience, yes, it's a bigger picture, but I think if we're really looking at buildings, there is an ROI case to be made, and I think there's an ROI case to be made to a CFO.
Thank you. We have another question from Adam Studley.
Hi, everybody. Thanks very much for the presentations. Very interesting, very important problem. I agree that in the current environment, CFOs are key, and that the problem we're facing in addressing them as a target audience is that the effect that they're creating doesn't match up to the accountability that they have. So they have local accountability for the finances of the organization that they're leading, but not accountability for the asthma that's caused in the neighborhood next door. And even within their organizations, they have a tendency to focus on what's easily measurable. So the point that was made about turnover is probably a harder thing for CFOs to get their hands around in general than other more direct measures of financial return. So these are kind of classic economic problems, right? Of focusing on the, cost accounting and measuring what's measurable versus measuring what's important, and economics and externalities. my question for the group then is, because I see we're getting short on time, is what can we at NAM do to change the dynamic? And what could the board recommend that would help make progress here? Some things that occur to me are to think of it in terms of two target audiences for information that we might generate. One would be the CFOs, but the other might be policymakers who might be able to create change even if the CFOs didn't agree with it. And it's actually the case that the accreditation and compliance people in health organizations do trump the CFOs. Even if it's a loss, if the Joint Commission says do it, then hospitals will do it. So I heard about an unnamed organization that sets rules about how buildings have to be built. And I wonder if we could think of that organization as a possible target audience, and the CFOs as a target audience. And then in terms of methods for moving forward to generate information for that group, Academy Health has been working on what they thought of as complex health systems interventions, and how you evaluate them, but that also that relates to how you tell stories about them and how you change the narrative, as our third presenter suggested was so important. So I'm
going to ask our respondents to keep their questions short. We have the responses short. We have 2 more people in the queue, and we have 10 more minutes, 9 more minutes.
Well, in answer to that, we talked about that here at GW on Friday in a webinar with our students. I think one solution might be working through the Joint Commission on Accreditation of Healthcare Organizations, because in the post-COVID-19 world, I would not be at all surprised if the Joint Commission looked at some new and different kinds of standards to help address this issue. I'll cut it off there.
And I would add, Gary, a couple things that would change everything is if we could change CMS reimbursement requirements that need hospitals do climate resilience planning the way they have to do emergency planning, and add that dimension, that would get everybody focused on that. And the other side of the equation is financial incentives, grants, loan programs that allow the safety net hospitals, the hospitals and clinics that don't have the resources that a Cleveland Clinic or a Kaiser or Partners has to make these initial investments in these kind of strategies so that the payback could be coming to them sooner. Those 2 things would have huge impacts.
Yeah, and I want to follow on the question about TJC and CMMS. So I sit on all these groups that write the code. Absolutely, you guys should engage with us and them. I think there's a huge role for you to play there. CMMS and TJC follow us often, but CMMS in particular does so very, very late. And there's all kinds of issues about code changes and new technologies that are being prevented from helping healthcare systems do better because CMMS is so slow to adopt new standards. But the other thing I was going to point out in terms of reimbursement rates and your externalities question, which is exactly right, classic economics problem. I think the move towards population health is exactly what's required, because I think that changes, it's no longer about what happens inside the hospital, right? It now starts to become about what happens to the community. And I think as we change our reimbursement structures in that way, it allows us to address those externalities in a way that's very difficult to get at in any other way.
Our next question is from Terry Fulmer.
I don't have a question. I didn't put my hand down.
Okay, so our next question is from Thomas Dougherty.
Yeah, I would just like to follow up on the resilience point. I think, and to tie some of this discussion together, I think resilience is a very important concept, but it means different things to different people, and it's also a jargony term to the general public. They don't really know what that means. I think resilience as a term means the ability of an object or a system to retain its shape when it's being stressed. So a tire will retain its shape when it bounces, but it will lose its resilience if it's punctured, right? And I think what's talking about here is that we're arguing about different kinds of resilience. The CFO is thinking about financial resilience in the hospital. public health people are thinking about community health. So I think what we need to do is, and what some of these discussions can do is help bridge different kinds of resilience and realize that one kind of resilience, such as disaster resilience, it actually is financially resilient, because what we're doing is they're holding into their systems. And so I think making sure that people understand what resilience means in different contexts and in a very visceral way, a family is resilient or not, etc. That's going to be important, because otherwise we're just arguing at different kinds of resilience, and it's a systemic issue.
Is the business insurance industry, the people who insure hospitals, are they another possible target audience?
I think so. You know, where Richard Frank put in, you know, the idea is if hospitals are investing in climate resilience and climate smart strategies in general, they could have a better rating. They could get a better deal. They could have a better bond rating for their investments. So that's definitely a possibility.
Okay.
So Richard Frank has his hand.
My comment was actually more along the lines of how we handle terrorism insurance, which is that we agree as a society through government to protect hospitals in the time of disaster so that they don't have to set aside as much money to protect themselves. And in return, they would make the kinds of investments we're talking about here. And that seems like a message for policy that, you know, evidence could be brought to.
Great idea. Well, we've been pushing you guys pretty hard, not in the sense of doubting your message, but in the sense of knowing how hard it is to make progress on issues that are core to healthcare, much less issues that struggle as not being seen for whatever psychological or historical reason as core to healthcare. It's not to say they won't be seen as core to healthcare in 5 or 10 or 15 years, but there still is a translational challenge. So we've been pushing you, because at least I have, because the better the arguments and the more they speak to the decision makers, the more likely this idea is to spread, and beyond the very early adopters. But we are close to the end of our session, so I want to thank our panel for a really provocative and informative session, and thank our board members as well. And I think if we can adjourn for the break a minute early, we give people an extra